Every 20 seconds in the world, someone who has diabetes gets an amputation. And within 5 years of getting an amputation, most of these people actually die. So foot screening is extremely important to prevent an ulcer, which actually leads to an amputation. For one of the basic diabetic foot assessments, we have a short little guide that we're going to explain to you, and it has 3 simple steps.
You could please take a seat for me and take off your shoes and your socks.
So the first thing is to ask your patient to take their shoes and their socks off when they get into the room. And as soon as that is done, you are going to visually inspect the feet. Very quickly, make sure all the nails are nice and short and cut, or if there's anything wrong with the nails, you will note that. You check in between the toes to make sure that there are no cuts or abrasions in between the toes. You check the overall skin texture. Is it healthy skin? Is it dry? Is it wet? And then obviously you look for lesions. A lesion can be anything from a scrape to a wound or a callus or a corn, and that you will note for your first part of the assessment.
Have you ever had an ulcer before? Not on your foot? Not anywhere on your leg?
No.
All right. Do you ever have any pain in your calf muscle when you walk to a point where you need to stand still?
Just sometimes when I go down the stairs.
Sometimes when you go down the stairs, okay. And tell me, any burnings or tinglings at night?
The second part of the assessment is to do the neurological examination, which we do with a 10-gram Einstein monofilament, and we test 10 specific areas on the foot. So first, you always explain to the patient that it's not a needle, because a lot of patients do get a fright. You demonstrate on your arm or your hand what the bending of this monofilament action is going to look like, and then you move on to demonstrate on the patient's hand so that they can get the feeling of what it should be feeling like. As soon as they've noted that they can feel it, then you will ask them to close their eyes, because with a neurological examination, you don't want someone to see what you are doing, because then they are actually going to see what they feel and not feel what they feel. And then you start off, as soon as their eyes are closed, by pressing the monofilament and pressing it into a C shape for 1 to 2 seconds, and then you leave it off. So you test the pulp of the big toe, the pulp of the third, the pulp of the 5th toe. And then you go on to the metatarsal area. You go to number 1, number 3, number 5. You do 1 little pressure area in the arch, 1 on the heel, and 2 on top of the foot. When you test these areas with your patient's eyes closed, they should be saying yes when they feel something, no if they don't, but obviously if they keep quiet, it means that they are not feeling anything. And sometimes patients are very perceptive and they can actually tell you, I feel it, but not as strongly as I felt the first one, which then indicates that they are quite good at still depicting what they are feeling. Out of the 10 points, you always give a score out of 10. 10 out of 10 obviously being that everything is perfectly fine in the feet and they are still feeling everything. If a patient feels 6 points or less, it means that they have quote-unquote failed the test, which then just means that they are not feeling as well as they should and they have loss of protective sensation, which puts them into a higher risk foot category. If you are limited with time and you cannot do all of the 10 sites, then you can test 4 sites underneath the foot only, which are the areas that are most at risk for ulceration. The tip or the pulp of the hallux, on the ball of the foot area, which is known as the plantar metatarsal area, area number 1 underneath the big toe and area number 5 underneath the 5th toe, and then a point on the heel. And if you are even more strapped for time and you don't have a monofilament on hand, You can use your finger only by just lightly touching those 4 areas, and this is known as the Ipswich touch test. The third and final part of the foot screening is to palpate 2 specific pulses in the foot. The one is the dorsalis pedis and the other one is the posterior tibial pulse. How you will actually find the dorsalis pedis is if you look in between the first and the second toe, that web space. You track it up towards the midfoot where the bony part of the foot is, and then you use fingers 1, 2, and 3, or index, middle, and ring finger, and then you lightly press on that area, and you should be feeling a pulse immediately. That is the normal anatomic position, but you can definitely move your fingers around a little bit if you don't feel it initially at first go. When you then move on to your posterior tibial pulse, is if you look at the bony part of the leg on the inside. It's called the medial malleolus, which is the bone that you feel, that's your ankle bone. You pull a line diagonally across to the heel. Then there's this little soft pocket. In there you should find the posterior tibial pulse. And then again you use fingers 1, 2, 3 from index finger to ring finger, pressing down. You should be feeling the pulse. Now when you note that on your chart, you will note that the pulse is either present or absent. Absent is not good. That means the patient needs to be escalated to a specialist. But if the pulse is present, you can actually also note whether it is strong or whether it is weak, so that when you redo your test in 1 year's time, just to make sure that blood flow is still the same or it has deteriorated. Just doing a regular screening can ultimately prevent ulcerations, which is the wounds, and then by way of preventing an ulcer, we prevent an amputation. And by preventing an amputation, we save your life.
As healthcare professionals, it's very important for us to just inform or warn the patients that next time we're going to look at your feet, to protect their dignity so that they come prepared, then they can wash their feet and maybe wear clean socks, and so that, they're not embarrassed to take the shoes off.
By the nature of my job, I look at feet every single day. I have seen the worst, I have seen the best. So generally when someone comes into the rooms and they say, my feet might be stinking, can I not get something to wash it off? I just generally tell my patients, listen, I don't even smell the foot anymore. I am here to do a job, and I'm here to make sure that your feet are kept on your body. So I don't care what they look like, I don't care what they smell like, as long as I can take a look at them to make sure that everything is okay. If they still feel uncomfortable, I will have my bottle of sanitizer, my Hibitane, with me, and I will spray their feet, and then they are quite happy for me to have a look at their feet.
It's very important to empower the patients, give them that confidence to feel comfortable in taking their shoes off, because once they know that, it's important for doctor or nurse to look at my feet at least minimum once a year, so that when they go there, they don't feel like bad when they're taking their shoes off and they're just asking the doctor or the nurse, can you please look after my feet this year? No one looked at my feet yet.